Okay, well, maybe we'll make a start. Can you see my screen?
Yes.
Yes.
Thank you. Again, I'm sorry to be delayed in starting today, but I had a patient I had to deal with. So today, I thought it would be good to talk about the neurological examination of children. And the reason being, I think we often learn about respiratory examination and cardiovascular examination, but I think we often don't practice a sort of a disciplined neurological examination. I want to tell you today about at least a way of thinking about neurological problems that might help in the way you see and manage children with neurological disease. So some people would say that the neurological examination of children is the same as for an adult. And in some ways that's true, because we assess the conscious state, we assess the peripheral nervous system, and in doing so we assess tone and power and coordination and reflexes and sensation. If you're doing it in an older child and in a child who's very sedated, then that's what we do. And then we check the cranial nerves. So we would do the same as what you do for a neurological examination in an adult. But mostly the neurological examination of children is actually quite different. It's actually based on an adult will lie there and allow you to assess their tone and power and coordination and reflexes and their sensation and do all their cranial nerves, but a child won't necessarily. And so the neurological examination of most children is actually different to adults. It actually has to be tailored to the presenting problem and the symptom the child has. So you tailor your examination to that. It has to be opportunistic. That is, it has to be based on observations that you can make by standing back and looking at the child. And so you can observe the child's function, what they actually do, their activity, their behavior, their movement, their interaction. And so your powers of general observation become very important. And you have to translate those powers of observation into a description of what the child can do, what their posture looks like, what their activity is like, etc. And then the neurological examination of many children is integrated with the general examination, because many neurological symptoms have non-neurological causes, such as weakness and hypokalemia, or seizures and meningitis. So there's often a need to do a general examination at the same time as you're making neurological observations. And when you're examining children, you have to take into account the child's age and their developmental stage. And all these things mean that it's a bit different when you're examining a child than when you're examining an adult. On the other hand, you still have to be systematic in your approach. And at the end of it, you should still be able to say the pertinent neurological features that you can say for an adult, that is their conscious level, what their peripheral nervous system is like, and their cranial nerves. And when talking about their peripheral nervous system, say something about their tone and their power and their coordination and their reflexes. And sometimes you can say something about their sensory changes as well. So you still have to be systematic, but on the other hand, you have to be opportunistic, and you have to use your powers of observation a little bit more. Now, what I wanted to sort of really try to teach today is that when you're faced with a neurological problem, often we try to say what the diagnosis is first up. But in fact, I don't think that's what we should do. We should try to say where the problem is, right? Not what the problem is. That should come second. We should try to be able to say whether the problem, what I mean is, where is the lesion? Where is the neurological injury or lesion that the child has? Is it in there? Is it central? That is in their brain, in their cortex or their cerebellum? Or is it peripheral? Is it in their spinal cord or their anterior horn cells, which is part of the spinal cord, or their peripheral nerves, or their neuromuscular junction, or their muscles? And is it unilateral or bilateral? And if you can by looking at the clinical signs the child has and the clinical picture the child presents with, you can say where the problem is, then you can start to get a better idea of what the problem could be. Right. And so I guess my main message when trying to teach people how to do a neurological examination is always ask first, where is the problem? And then you can ask, what is the problem? All right. Now, I mentioned the different levels of the neurological system, and from the clinical signs, you can say whether the problem is at the level of the cerebral cortex or the cerebellum or the brainstem, or the spinal cord, or the anterior horn cells, or the peripheral nerves, or the neuromuscular junction, or the muscles, right? And so it is possible by understanding, by doing a full neurological examination and understanding the neurological signs that occur at different levels of the nervous system, to be able to say where the problem is. And that gives us a really good idea of what the problem is. Okay. So this is a very big slide, and I'll send it around so that you all have it. But what I've tried to do is to identify the abnormalities that occur at all different levels, from the cerebral cortex to the cerebellum, to the brainstem, the spinal cord, the anterior horn cells, the peripheral nerve, the neuromuscular junction, and the muscle. And these are important. You might think that these are just there's no point in making a distinction between these different levels, but there is, because different pathologies occur at different levels. All right. And so if you can say confidently where the lesion is, then you've got a good idea of saying what the lesion is. And so in the last column, I've written some examples of the diagnoses that you see at different levels. And so, for example, that's right. I'll just mute them. So, for example, at the level of the cerebral cortex, then neurological lesions could be a stroke, or bleeding, or some congenital malformation, or a tumor, or a tuberculoma. Lots of different things that can occur at the cerebral cortex lesion. But of course, if you've got something at the peripheral nerve or the anterior horn cells, then the causes are quite different. Polio, spinal muscular atrophy, or Guillain-Barré syndrome. So by working out the level, by working out where the lesion is, you get a very good idea of what the lesion is, right? What the diagnosis is. And that's why you always start with where is the lesion. For the next column, I've said what the conscious level is for the child at different levels. So for example, if a child's got a cerebral cortical lesion, whether it's a stroke or a tuberculoma, then they will usually have an impaired conscious state. That they will often have impairment of communication, so they'll have a reduced conscious state. They'll often have dysphasia or visual neglect or some other higher cortical function impairment. And so whereas children who have peripheral nerve lesions, they have a normal cerebral cortex. They're usually quite alert. They're weak and floppy, but they're usually quite alert. And so again, by understanding the different features at different levels, you can get a good understanding of where the lesion is, and from that you can get a good understanding of what the lesion is, right? And so similarly, if you've got a lesion at the cerebral cortex, the tone is usually increased. Usually there's an element of spasticity, and the power is decreased. Usually, of course, with all different levels, the power is decreased, but the reflexes are increased if there's a cerebral cortical lesion. Whereas if you've got a peripheral nerve lesion, like an anterior horn cell lesion, or a peripheral nerve lesion, or a muscular lesion, then usually the reflexes are reduced. So again, understanding the simple neurological, the common neurological features of the conscious level, the power, the reflexes, the tone, and the coordination and the sensory function, you can get a good idea of where the lesion is, and therefore ultimately what the lesion is. So I'll send this table around. I think it's just useful to think in these terms when you're doing a neurological examination of a child. We can discuss this at the end if you like, this table. And I think that there are some common clinical syndromes that occur in paediatric neurology. And I just want to go through a few of these, because if you understand the clinical syndrome that a child presents with, then you can get a good idea of what the causes are. So the first one is the floppy infant. That's a relatively common clinical syndrome. Another one is new onset of difficulty walking. A child presents with new onset of difficulty walking. Another one is a hemiplegia. All right, the child presents with a hemiplegia, like weakness down one side, and then the child with delayed walking, and then movement disorders. If you think about paediatric neurology in these terms, where there's a number of common clinical syndromes, and then you can determine whether where the lesion is and then what the lesion is. We'll go through a few of these as examples, so to try to assess it. So, for example, if you've got a baby, a hypotonic infant, a baby who's floppy, then the floppy baby usually has their arms abducted. They lie in a sort of frog-like posture. Their arms lie flaccid beside their body. There's a lack of anti-gravity movement. They usually, though, if they're, depending on where the lesion is, they may either have a normal conscious state, they may be awake and alert, or they their conscious state may be depressed. And from that feature, the babies can have central hypotonia or peripheral hypotonia, and you can make a distinction by the level of alertness that the baby has. So you need to assess the level of alertness, you need to assess the posture of the baby, assess their degree of floppiness of their limbs, and by that you can do what's called the traction test and the vertical suspension test. I'll explain these in a minute, and then horizontal suspension. I think you've practiced this in terms of a developmental examination, but it's also a neurological examination. So, for example, the traction test, you lie the baby down and you pull the baby gently up with sustained traction on the limbs, so their arms are straight, and you watch to see what their head does. And a baby who's more than a month of age should have some degree of head control. Their head shouldn't be completely floppy, and their neck shouldn't go into full extension. But by about 2 months of age, they'll be able to bring their head up in the midline with their body as you pull them up, and they should have some, when you pull them, they should have some tone in their limbs. If they're very floppy, then they'll have no tone at all, and their back will just arch and their head will become floppy. So that's extreme hypotonia. So when you pull the baby up, the examiner should feel the infant pulling against the traction. They tend to pull just a little bit, and as they get older, they pull even more. And they should, as they get older, they should have flexion of all their limb joints at their elbows and their knees and their ankles. If they don't have flexion, but they've just got extension and complete floppiness, then the baby's has a hypotonic syndrome. The clues in working out whether or not hypotonia is central or peripheral relate to a number of things. And so for the first thing is to assess the conscious level, as I said. And if a baby's floppy and they've got altered conscious state, they've got severe impairment of their conscious level, or they're unconscious and unrousable, they don't open their eyes, they don't cry, or they've got an abnormal cry, or they've got eye deviation or eye abnormalities, then probably the hypotonia is central. That is, it's coming from their cerebral cortex. Often babies that have got central hypotonia have this feature called fisting, which is, I'll try to do it with my hands. Their thumb is inside their palm like that, and their thumb is down like that. Not always, but often. If you see fisting of a baby, then often they'll have a baby with central hypotonia. Often that'll be central. The other way to examine for hypotonia is to lift the baby up underneath the armpits, and if they slide through, then they've got hypotonia. And you can again work out whether it's central or peripheral based on their conscious state, fisting of their hands. This sign called scissoring of their legs in ventral suspension. If you lift the baby up underneath their armpits and they just slip through, but their legs are crossed over, they have what's called scissoring, like scissors, their legs cross over, then that is a sign of central hypotonia. Sometimes usually babies with central hypotonia will have brisk reflexes. And sometimes they'll have upgoing planters as well. And they may have abnormalities of other organs if they've got a congenital abnormality, for example. But you can make a distinction, even in young babies, between central and peripheral hypotonia by looking at these specific signs. If a baby's got peripheral hypotonia, usually they've got reduced tendon reflexes and sometimes muscle atrophy. And sometimes they'll have this feature called fasciculation. You look at their tongue and they'll have a twitching of their tongue. That's called fasciculation. And that's a particular form of peripheral hypotonia involving the peripheral nerves. But their conscious level may be normal. They will still be able to open their eyes. They usually will be able to look around, but they'll just be very weak and floppy. And usually they have no other abnormalities of other organs. So our job in the floppy baby, the hypotonic baby, is to make a distinction between central and peripheral hypotonia, because it gives us a good indication of where the lesion is. Right? If it's central, it's obviously in the cerebral cortex. And if it's peripheral, it's probably in the anterior horn cells or the peripheral nerves or the muscles. Okay. There's a variety of different causes of peripheral hypotonia, but I wanted to just highlight one or two that are quite common. And one that I think is probably more common than we realize is, there's two that are quite common that I think we sometimes miss. And one of them is infantile botulism. And this is it's a bit like tetanus, but it causes, instead of spasms, it causes floppiness. And it's caused by Clostridium botulinum. So not Clostridium tetani, but Clostridium botulinum toxin. And that blocks, remember we've talked about the way neuromuscular junctions function, and that is there has to be release of acetylcholine at the peripheral nerve that stimulates the acetylcholine receptor in the muscle and leads to contraction. And with Clostridium botulinum, that blocks the release of acetylcholine at the neuromuscular junction. And these babies are usually somewhere between 2 weeks and 6 months of age, and they present usually with hypotonia, floppy babies that are often failing to thrive. They will usually be quite alert though. They'll still be able to open their eyes. They have severe and progressive paralysis. We might think of them as an AFP, acute flaccid paralysis, and they are like that, like a baby with acute flaccid paralysis, but it affects all their limbs. They often live in dusty environments. So most of the children I've seen with infantile botulism come from environments around rivers that are very dry, where there's a lot of dust, sometimes where there's agriculture or construction, and that's where the spores of Clostridium botulinum exist. And usually they're constipated. So these babies are often present, if you ask the question, they're often constipated and they have poor feeding. And the clue, you can make a diagnosis by the floppy baby with constipation who has ptosis, that is their eyelids don't open, and they have dilated pupils, very dilated pupils with a poor light reaction. And sometimes these babies are even thought to have a central brain injury because of their dilated pupils. But in fact, it's, if you see dilated pupils with ptosis, like partially closed eyes in a baby who's floppy and constipated, then you should think of Clostridium botulinum. And usually the treatment for this is just respiratory support, because they're so floppy, often they don't take adequate breaths. And so you provide respiratory support and feeding. And just like tetanus, you have to look after these babies for many weeks until they get better. Just like all babies who have peripheral nerve problems, you shouldn't use gentamicin in these babies because it can make their peripheral nerve function worse. So I just think it's one of these diseases that we don't often think about. When we see floppy babies, we often just call it AFP, acute flaccid paralysis, and think it might be Guillain-Barré syndrome. But just look at the baby's pupils and ask the question about constipation, I think is the key things to diagnosing infantile botulism. It's an important diagnosis to make. If you can get the babies over the infantile botulism, just like children who've got tetanus, then they get better and they are normal afterwards. obviously you give them antibiotics, penicillin for the botulism, but Clostridium botulinum. But most of the support, most of the treatment is supportive for their respiratory function. The other causes of hypotonia in infants, there are many causes of hypotonia, and I just wanted to go through a few that are common. The first one that's important is hypokalemia, and we see this quite a lot, don't we, with children that have severe diarrhea. They might come in with a potassium of 1 or 1.5, and they're very floppy infants, and you correct their potassium and rehydrate them, and suddenly their hypotonia resolves. So if you see a baby with diarrhea and floppiness, then think about hypokalemia. If you see a baby with floppiness and constipation, then think about botulism. Sometimes newborn babies can have hypotonia because of spinal cord injury occurring at the time of birth, such as birth trauma. And then there are other conditions that will give hypotonia, and these babies are floppy from the time of birth and all throughout infancy. I won't go through these, but a few of the ones that are important to know about. Obviously, Down syndrome babies are more floppy than normal, and then babies who've got this condition called spinal muscular atrophy, which is just a problem of the peripheral nerves. It's a bit like AFP, but it's a congenital problem. Yeah. And then lastly, babies who've got Prader-Willi syndrome, which is another condition that most people know of as causing extreme obesity in childhood. But in fact, in infancy, these babies present with floppiness. They're very hypotonic. We'll go on to the next clinical syndrome that's common, I think. Remember I said children present with some clinical problems. So hypotonia or a new onset of difficulty walking. And this was I just want to go through this case. This was a case of a 12-year-old boy who had progressive weakness of his lower limbs over just 2 days and back pain. And then after that, he could only walk with assistance. His father had to carry him a bit, and he could move his legs a little bit, but not very much. And then even over the last 24 hours, he'd become unable to walk and he was bedbound. On examination, his conscious state was normal, and his upper limbs were quite strong with normal sensation. His upper limbs were just normal. They could normal power, tone, reflexes, etc., and normal sensation. But his lower limbs his tone was much increased, and his power, he couldn't elevate his leg beyond against any resistance. He could just shuffle his legs in the bed a little bit. His reflexes were very brisk, and his sensation, he could say that he had pins and needles in his legs, abnormal sensation in his lower legs, some pain shooting down his legs, and his coordination, he couldn't do the heel shin test, but his upper limbs were normal, and he had a palpable tender bladder. Where do you think the lesion is? When you've heard that story and seen that examination, remember we always should ask not so much what is the diagnosis, but where is the lesion, right? So where is the lesion in this boy?
He could have a spinal issue going on.
Yes, that's right. He seems like he's got spinal cord compression, doesn't he? And it must be somewhere in the thoracic or lumbar spine, because his upper limbs are normal, but his lower limbs are paralyzed with evidence of corticospinal tract involvement. And so yes, so as I say, given that he might have a spinal cord lesion, what could the lesion be? What do you think? What are you thinking about? So we've thought about where is the lesion. Think about what is the lesion. Okay, no one wants to have a go. I'm sure you can think of some things that would cause spinal cord compression. I'll just give you one more moment, if you like, to tell me some things that might cause spinal cord compression.
Someone typed transverse myelitis, Prof.
Yes, that's right. So there are some things that cause, you can think about it in terms of things pressing on the spinal cord from outside, or some sort of inflammation or lesion of the spinal cord itself. And so what Dr. Alto has just talked about is something within the spinal cord itself. So a transverse myelitis or inflammation of the spinal cord itself, or there could be an infarction like an ischemia to the spinal cord, or something causing compression of the spinal cord from outside. Has anyone got a thought about what could cause compression of the spinal cord from outside?
TB of the spine.
Yeah, good. TB of the spine. Like if this was Pott's disease, this would fit with Pott's disease, wouldn't it? And with TB of the spine, often you get an inflammatory mass that's causing compression of the spine, or you get the wedging of the vertebral bodies, and that can cause compression on the spine. So TB of the spine, yes. What else?
Acute trauma or TB of the spine?
Yes, TB of the spine. The other one was acute what?
Trauma.
Yeah, acute trauma, very good. And acute trauma could cause a hematoma that might cause compression of the spine. That's right. Or it can cause directly a spinal cord lesion from a fracture of the vertebral bodies. That's right. There's something else that might cause spinal cord compression in this way. We've thought about TB of the spine. We've thought about trauma or hematoma, or something internal such as transverse myelitis or ischemia of the spinal cord. What else?
A paravertebral abscess.
Yeah, a paravertebral. Yeah, good. A paravertebral abscess. That's right. So there could be like osteomyelitis of the spine with a paravertebral abscess. Very good. And lastly, well, anything else? Perhaps a spinal cord
tumor.
Yeah, someone said it. Perhaps a tumor, a spinal cord tumor. So now once, remember, the clinical syndrome is the new onset of difficulty walking. You've identified that this is most likely, based on the clinical picture, a spinal cord lesion, and that helps us a lot in understanding what the differential diagnosis of that particular clinical syndrome is. And you can then go through, think about, well, if it was a tuberculoma, I need to collect certain information to try to identify whether this child has TB. Or if it was a paravertebral abscess, there may be other clinical features that would suggest a staphylococcal infection or an abscess. Or if it was a trauma, I can ask about a history of trauma. So you can see by thinking in that way, you can get much closer to a clinical diagnosis than before. So this was what this boy presented with, and I just wanted to show you. I mean, again, as I say, we ask ourselves, where is the lesion, followed by what is the lesion? And I just want to show you the. So this was the boy who presented, and I wonder if you can see what's going on here. This is a chest X-ray of this boy, a 12-year-old boy who presented with 2 days of difficulty walking. Well, what can you see?
It's a paravertebral shadow in the thoracic spine.
Yes, that's right. Exactly that. And so from this, you can't say necessarily whether it could be a tuberculoma or it could be a paravertebral abscess, but or even a hematoma potentially from trauma. But you can say that there's you can see this is the heart, the shadow of the heart, and you can see this line coming down here. This opacity behind the heart border, and and adjacent to the vertebral body. So this boy had a paravertebral abscess. Yes. And this was his other X-ray. You can see the paravertebral abscess, and you can see there that there's been some bony destruction of the vertebral body. And so even with plain X-rays, you can make a good diagnosis of what this child had, either a tuberculoma, probably with the wedging of the vertebral bodies, or a paravertebral abscess. So you would treat this child with TB medicines and antibiotics to treat a paravertebral abscess, and you'd get the surgeons involved in terms of their decompressing his spinal cord. So the point is, if you've got a child who's got new onset of difficulty walking, then think about where is the lesion. It won't always be a spinal cord lesion. It might be something else completely. It might be at another level. But if you've got a spinal cord lesion, then, as I said, the conscious state is usually normal. The tone is usually increased, sometimes decreased, but usually increased below the lesion. The power will be decreased below the lesion. The reflexes are usually increased below the lesion. The coordination will be limited mostly by the lack of motor power the child has. And the sensory function is often decreased or absent below the level of the lesion. But sometimes children with spinal cord lesions and other peripheral nerve lesions will also have altered sensation. They may have increased sensory changes, like they may have pain or pins and needles in their legs. And then you can think about the possible diagnoses once you've worked out where the lesion is. So it could be trauma or an abscess or Pott's disease or transverse myelitis or a tumor, right? Or a hematoma or something like that. So the point is to ask where the lesion is, and then you can think about what the lesion is. Another clinical syndrome, so we talked about the hypotonic baby, and we've talked about the child with difficulty walking, new onset of difficulty walking. And the third clinical syndrome is a child who presents with a hemiplegia. And you always need to ask yourself again, where is the lesion? Where is the problem? Well, if you've got a hemiplegia, that is weakness down one side of the body. One side of the body is normal or near normal, and the other side of the body is weak or immobile or hypertonic, like increased tone, or floppy. There may be hyperreflexia, often upgoing plantar reflexes. And sometimes the child will have other impairments of function, like speech impairments or visual neglect. They may have some other higher functions that are abnormal. And so just recognizing this is important. And I see a lot of children with a hemiplegia that is often missed on examination. And it's often missed because people don't look for symmetry and look for abnormal asymmetry. So when you're examining a child, just stand back and just watch over the entire examination and see if you can see symmetry of movement of the right side and the left side. And if you see that one side is obviously not moving, then think to yourself, why might that be? You think to yourself, could it be because the baby's lying on that side, or because there's an IV drip cannula in that side, or there's a splint on that arm? And then correct that. So change their position and think to yourself, is the baby still not moving one side relative to the other side? All right? Because I see a lot of hemiplegia that just gets missed, and then people never get to the point where they can actually ask the question, where is the lesion? So we should be asking, where is the lesion? And if you've got a hemiplegia, then the lesion is almost always in the cerebral cortex on the contralateral side, on the other side of the body, of course, because the right cerebral cortex controls the left side of the body, and vice versa. So usually the lesion is on the cerebral cortex on the contralateral side. Now, of course, some children have a severe hemiplegia on one side, and they might have some neurological features on the other, and then probably they've got bilateral cortical involvement that's just different in severity. Then you should ask the question, in terms of having worked out from the clinical picture that the lesion is in the cerebral cortex causing a hemiplegia, then think, is it sudden onset or is it slowly progressive? right? And sometimes you can get an idea if the parents have noticed the hemiplegia from, is it sudden onset or is it slowly progressive? Because there are some conditions that have a sudden onset hemiplegia, like a stroke or trauma. And then there are some conditions that might have a slower onset hemiplegia, like a tuberculoma that is growing slowly and manifests. So sometimes hemiplegia will be of gradual onset over several days or a week or more. A brain tumor or tuberculoma may cause something that's more slow onset, but there are lots of different causes of acute onset hemiplegia, such as a stroke or trauma or a hemorrhage. There's lots of different causes of hemiplegia, and I won't go through them all, but these are the different. When you've decided that this is a hemiplegia and therefore a contralateral cerebral cortical lesion, then you've got to think to yourself, well, what could it be? And what could it be depends on the rest of your clinical examination, whether there's other signs, for example, of congenital heart disease, and the child might have had a cerebral embolus or rheumatic heart disease, or signs of infection like meningitis and the baby's had a sort of an inflammatory cerebritis, or whether they've got a venous sinus thrombosis. There's lots of different causes of a hemiplegia, and the overall examination can help you with that. For the slowly progressive hemiplegia, like a brain tumor or a tuberculoma, are the top of the list causes. So after you've decided that the hemiplegia is due to a cerebral cortical lesion on the other side of the body, then look for other signs, like look for fever or other signs of infection that might indicate a cerebral abscess or meningitis or tuberculosis. Listen for a heart murmur or examine for cardiomegaly so that you see whether there's evidence of congenital heart disease or rheumatic heart disease. Look for a rash or vasculitis or signs of rheumatic heart disease, and examine to see if the child's got raised intracranial pressure. Do they have sun-setting eyes, or do they have a bulging fontanelle or split sutures, to see if there's any signs of raised intracranial pressure, like you might see in a child with a hemiplegia from a hemorrhage or a tuberculosis or a tumor. And could the child have recurrent hemiplegia? There are some children that have a hemiplegia that goes away and then they get it back again. And that is seen sometimes in hemiplegic migraine. And then sometimes there's a history of other things like cancer treatment that can lead you to the notion that the child's got had a stroke from the medications used for cancer treatment. That's uncommon, but it does occur. So the point is that there's lots of different causes of hemiplegia, and by history and examination, and sometimes by doing simple radiology, just plain x-rays, even looking to see if there's signs of raised intracranial pressure on the x-rays, we can get a pretty good idea of what the diagnosis is, not as well as where it is. And then sometimes, of course, we need to do CT scans or other scans to identify what the lesion is. Now, lastly, the last clinical syndrome I wanted to discuss was the child who has delayed walking. And this is a relatively common syndrome as well. And often delayed walking is often very benign. There's a wide range of when a child will walk. Boys are usually slower at walking than girls. Sometimes even a boy at 18 months will have only just stand and start walking. But if a child gets to 2 or 2.5 and they still can't walk, there must be a problem there. And so I'm going to just talk about the clinical syndrome of the child with delayed walking. And so this child was a 2.5-year-old boy who still didn't walk. He could sit without support from about a year of age. So he was delayed in sitting, because a child should be able to sit from about 6 or 8 months of age, but he could only sit from 12 months of age. He could pull himself to stand, but he couldn't stand independently. And he was alert. He played with his toys. He said many words, and he responded to sound. He used simple language. So this boy's got an isolated gross motor delay, and you need to think about why why that might be. This is a little bit more complicated, and it merges into the neurodevelopmental. Remember, I said at the start, when we do a neurological examination, often what we're doing is a neurodevelopmental examination. And so I think I use one of these types of charts, which I've shared with you before, but I usually use a chart like this because it helps me understand where the child is up to in terms of their development. And so this boy was able to do many things that were normal for his development. He could move and hold his head in all directions. He could sit well with support, although he'd done it, he'd been delayed in that. But by the age he was, by 2.5, he could sit well. He had good fine motor skills. So he was okay for these things. I've circled them in green. But he was quite delayed in pulling himself to standing, and he couldn't walk. So he had gross motor delay without some other features of developmental delay. And I think when you're describing a child's developmental delay, it's useful to describe it in these terms, what they can do in terms of their gross motor function, their fine motor function, their vision, their hearing, and their socialization. Right? So I won't go through this more today. We'll talk about neurodevelopmental examination, but if you do that, then you can, if you describe it like this, you can get a good understanding of where this child's up to. So this boy, on examination, he had a normal conscious state. As I said, his tone was normal or a bit floppy in his legs, and he had, in his proximal muscles, his power was very low. His coordination was normal. His sensation was normal to the extent that could be done. And he had a mild scoliosis, a mild curvature of his spine. And he had very thick calves. It's hard to see from this picture, but this is a picture of his calves, and they were very thick. And when he got up from the floor, he could stand up by pulling himself to stand. And as he got older, he did this. He would try to get up like this, climbing up his legs. So can anyone recognize what that is, what that sign is?
Gower sign.
Good, Gower's sign, that's right. That boy's had Gower's sign, and all it tells you, it's not diagnostic, all it tells you is that he's got proximal muscle weakness, like his quadriceps are very weak. His proximal muscles of his arms and his legs are quite weak. And so when we think about the child with delayed walking, the lesion could be anywhere. It could be in the cerebral cortex or the cerebellum or the brainstem or the spinal cord or the anterior horn cell or the peripheral nerve or the neuromuscular junction or in the muscle itself. But from the clinical picture that I've shown you, then you can work out exactly where it is. And I'll just go to the table again. Now, this child had a normal conscious state, so he must be down here somewhere. Normal conscious state. He didn't have impaired consciousness, and he had reduced power and reduced tone. And so he must be down here at the peripheral nerve or neuromuscular junction or the muscle. And if you follow through on the table, he had a muscular weakness because of his very thick calves and by his Gower's sign, his evidence of peripheral muscle weakness. And so you can go through this sort of table and work out where the lesion is. So this boy had a muscle problem, and it was most likely some sort of congenital myopathy. So this boy had muscular dystrophy, a form of muscular dystrophy called Duchenne's muscular dystrophy, the most common form of it, and it only occurs in boys. And usually their body habitus looks a bit like this, with an exaggerated lumbar lordosis. They've got this scoliosis and lordosis. Eventually, by about the age of by the school age, they look like that. They always have delayed walking. And sometimes they have, when they're a bit older, like 3 or 4, they have Gower's sign. They have weak proximal muscles of their thighs and their shoulders, and they often have calf hypertrophy. They have very thick muscles that are still not strong. They're thick, but they're not strong. So they might seem to have big muscles, but they're actually mostly full of fat, and they're not very strong. These children, of course, by 15 years are often wheelchair bound. and they have a severe scoliosis, and they develop other problems as well. They can be treated and have delayed reduction in their progression of their disease, but unfortunately by young adulthood they usually succumb to severe lung disease. The reason to talk about muscular dystrophy is partly to show that there are some conditions down the bottom of this table where you just have a muscular problem. It's not a cortical problem or a spinal problem, it's just a muscular problem. And the reason I wanted to talk about it is because even though around the world Duchenne's muscular dystrophy is the most common cause of muscular dystrophy, in some countries and in PNG there are some other relatively common muscular dystrophies that have a better outlook. And sometimes there are whole families that have a form of muscular dystrophy where they have a lot of the clinical signs, but their muscular dystrophy usually starts a bit later. Usually when the children are about school age, they start to get to be seen to have muscle weakness. And sometimes it's a muscle problem, and sometimes it's a nerve problem like an anterior horn cell problem, but it's essentially a peripheral neuromuscular problem. And so we shouldn't think that they all will follow the same prognosis as Duchenne's muscular dystrophy, because some of them can live into adulthood and be better than that. So I guess I just wanted to say, go through a variety of different clinical syndromes presenting neurological problems and say how we make these diagnoses. So when we are trying to make a diagnosis, we should always ask, where is the problem, and work out what level of the lesion it is, and then ask ourselves, what is the problem based on that? And it may be helpful to use that table that I mentioned earlier on. And as I said, I'll send that around so that you can use it yourself if you like. I'm going to stop talking now, and I'm happy to answer any questions. That's just an overview of the neurological examination of children, and I'm happy to answer any questions that you've got. Thank you.